Okay, I gave talk to our neurosurgeons because they asked me to do it there, so I'll be short and sweet. So mainly this lecture is about short segment fusion and how to approach spine from the front, back, or side. There are basically three fundamental questions when somebody wants to treat somebody with a spine fracture. Is it going to be non-operative treatment or will be operative? Hopefully most of the time it will be operative and non-operative. Then if it's length of fusion, is the short or length or short segment fusion, and there is approach. Is it going to be done through the back or through the front, or we have to do it both? Okay. So the short segment fusion is the fusion one level above and one level below the fracture. Long segment fusion is two or three above or below. And these are examples of the short segment fusion that can be done. So one vertebra, one screw above, broken vertebra, one below. And also on the other side, we have these long segment fusions. So which approach we are going to take, anterior, posterior, or both, depends on comorbidities. If somebody is old, has a problem with the abdominal cancer, as a scarring or anything, so you cannot go from the front. So even if you have to go from the front, you cannot go through it. Then you have a fracture anatomy. Where is is there a big distraction gap there? So if there's a lot of jump between healthy vertebrae, then you have to think about maybe doing something to support it. Then you have a translation displacement, meaning if you have an injury to the soft tissues, then that changes approach too. And if spinal canal compression, so if you have a compression like this case, which is on the front, okay, it's hard to get everything from the back. And also, technical skills. Some people are more skilled to go from the front, some from the back. So it depends also on your abilities or your experience. Or some people say, I don't want to go from the front because I have a bad experience. So that takes into account. So, but fracture anatomy alone, how the vertebra is broken, cannot be used to determine the way how you approach this, because any fracture, unless person has neurological deficit, can be treated non-operatively. If you keep person flat for long enough, then that would be enough, okay, to heal. So you don't have to operate to anybody. You only have to operate somebody who has a neurological deficit. Okay, good. So how are we going to go, front and back, or just front, or just back? Depends also on the age. If somebody 80 years old, okay, maybe it's difficult to open his chest and kind of do something on it. Or if you have a general health is bad, if somebody rheumatoid arthritis, something, you have to think about, what material you're dealing with, and also patients' expectations. What do they want? They just want to get up and walk a little bit, or they want to jump around and have a bike and maybe go skiing. Compliance is very important because you have somebody who is overactive, who is debilitated, who is demented, or who is non-compliant. I have a patient with a fusion, and 6 weeks later, he was on a bike that he took from his cousin, who is 7 years old. And on that bike, he was driving around. So I said, well, so you have to know what you're dealing with. So you cannot do a Cadillac surgery for somebody who does not appreciate that. So also this patient selection depends on a surgeon. Surgeon has to know properties, mechanical properties of the screws, what that screw or rod can achieve, and also patient willingness to apply your complications. To ability to comply what you tell them. If you tell them don't do that, hopefully they won't do it. Or they have to understand the principles of that system, what you're putting in. It's not, oh, here's my back, I fixed it, now I'm going to go and run around. Okay, then you end up with the complications. And they also take the responsibility for his or her recovery. As Dr. Zubovic said, there's nowhere patient in that. Yeah, patient is the main thing, main player in all this. We just fix it together, but he or she has to heal over the next 3-4 months. Okay, so if that patient has to see, well, I'm the important factor in all this. These are different classifications. Descriptive that talks about you know, the 2-column fractures. These are descriptive complications. And there's a classification that talked about mechanism. Is it flexion? Is it extension? How the vertebra is broken. But none of them really doesn't tell us how we are gonna fix something which is broken. Okay, they are telling us the mechanism and how it's broken, but not how much there's a residual strength in that broken vertebra, because it's not easy. If you, it's the same thing. You take a brick and you hit it a little bit, and little chips come off, or you take a big hammer and smash it, and then you want that brick to hold the spine. That's why we have hold the wall. Like that's the same in the spine. This is the that's why we came with this load sharing classification. Which actually quantifies. If you want to do short segment fusion, quantifies should you go from the front or back, and you know. So here it is what it says. Load sharing is in a normal spine, 70% of forces go through the vertebral body. Once vertebral body is broken, the rest, when you fix it, goes through the spine, through the implants, bypasses it. But ideally, you would like to split that, those forces that go through the implants and goes through the vertebral body. So there is what we call load sharing. So the body shares a little bit carries a little bit of weight, and the implants carry a weight. Because otherwise, if you don't do it, this is what happens. You know, you see on the top, there's ideally fixed short segment fracture of the vertebra, which is nicely realigned. The screws are perfect, everything's okay. But what happens in the end? The vertebra starts slowly collapsing, and look at where the screws are on the top, because the screws didn't break, but the bone around it break, because it cannot hold all that weight. So why? Because why we did not think that this is. We did not calculate how much this broken vertebra carry weight. So all the weight goes through the implants. So based on that, we developed this load sharing classification, which is it talks about how much comminution the vertebra has, how far the fragments are apart, which is apposition, and also there's a deformity correction, how much actually we can correct of that vertebra when it's collapsed. So here's the first is comminution of the vertebral body. So if there's only 1/3 vertebral body is broken, we put it like 0.1 point. If it's 2/3 or 3/3, obviously, if somebody has only 1/3 broken, that's a minimal. That's a little one. And so there's a lot of force that goes through this. The 2/3 of the vertebral body can carry that weight in comparison to this grossly, there's a polarized. There's nothing that whatever you put on that, it's going to be a pancake as soon as you put weight on it. Now, the other one is that apposition or displacement, how much these fragments are pulled apart. So if they are very mildly, that we said it's a minimal displacement. If it's more than 2 millimeters over 50% of body circumference, we call it moderate. And then if it's widely displaced all over the body, it's called wide. So in that situation, this is measured on a CT scan, axial CT scan. So obviously, the vertebra on number 1 it has some potential to carry some of the weight and share it with the implants. The one on the bottom obviously doesn't have it. And also, this is deformity correction. Most of them are in some kind of a kyphosis. So if you have a very small angle there, so that a lot of its vertebra is there to carry it. And then if you have moderate, it's over 10, up to 10 degrees, and over 10 degrees, we call it severe. And based on that, here we can classify this fracture as has, you know, you see that its whole vertebral body is broken. The fragments are split in half, and on the right-hand side, we see the vertebra is very, very kyphotic. There's angles, so there's a lot of angles, so this vertebra is not going to carry a lot of weight. That means, if I put a screw above and below, it will not hold it, because everything will go on those, through those screws, and nothing through the vertebrae. Okay. So based on this classification, we kind of classify all the fractures from 3 to 9, and obviously the one that have a 3 points, they have a it's realistic to expect from them that they will carry some of the weight if you use short segment fusion. So, but if it's higher points, that's insufficient, this anterior support, and you have to, you know, support it from the front. So also this, this classification doesn't take in account if there's a soft tissue injury, ligamentous injury, when, here we go, this is called translational displacement that can be mild, but can be grotesque. And then these are called fracture dislocations. So there's not a lot of comminution of vertebral body, but majority is soft tissue injury. This one you cannot use this classification for. So here we go. Our preference is short segment fusion, one above, one below. And in that, we talked about this approach. So this is what happens. If you don't have a lot of, sharing between the forces and everything goes through the vertebrae, what happens is there's a lot of fracture, and then either screws will break or vertebrae break. Okay, so some things has to give. Okay, and the principles of treatment of these thoracolumbar fractures, that you have to restore the normal coronal and sagittal alignment. It's not good to make a distraction gap. A lot of times we used to reduce them, pull them up, they stretch them, and so that means that you are decreasing the blow that goes through the vertebral body. So what you have to do is to have to kind of leave them compressed, decompress them widely, but leave the vertebrae compressed, because if they are compressed, they have some potential to bear weight. And then in that situation, and also anterior strut grafting is sometimes necessary. Here are some examples. This is the L1 burst fracture with a mild spreading of the vertebrae. There is a mild there is the angulation of the kyphosis is small. A lot of potential for bear weight in the residual vertebrae, and we see that it's healed fine without that kyphotic deformity we saw in the beginning. On the other hand, this is the L3 burst fracture. Look at the CT scan, completely spread fragments. It's when you look on a sagittal CT scan in the middle, we see there's nothing there to where it's an empty box. So in that situation, if you put just one above, one below, it will break or lose alignment. In that situation, we go from the front, we take this, remove all this vertebral body, we put a graft here, and then fix it from the front. So we still achieve the short segment fusion, but with the other way. And now that instrumentation can support this. Okay. And sometimes, if you have a burst fractures like this one, that you cannot decompress everything from the back, then you have to go from the front, because there's so much comminution here. Okay, so comminution. So you have to fix it from the back, but then you have to go additionally from the front and support this, because if I just put it from the back, this all will collapse. So this is going both sides. Obviously, if you want to put 3 vertebrae above, 3 vertebrae below. Maybe you can go without going from the front, but in that situation you are fixing 6 vertebrae instead of only 3. So, so that's another option, putting long segment fusion, but we are not really a fan of those. So in conclusion, posterior anterior spinal instrumentation systems are very effective, but you have to carefully preoperatively planning and do meticulous surgical technique in whatever you are familiar with, and never make operative or non-operative decision based on only one factor. You have to do preoperatively and postoperatively to see what you can do. Thank you.